Thank you so much, Steve. Thanks everyone for joining us today for the webinar Occupational Therapy and Social Work, offering community-based approaches to support people living with dementia and their caregivers. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, on behalf of the Administration for Community Living Administration on Aging, I want to thank all of you for taking the time out of your busy schedules to join us to learn about how occupational therapy and social work within the world of dementia. So I want to thank Jane Gruner from Nevada Senior Services and Stephanie Shivers from LiveWell in Connecticut for sharing their wisdom with us. We're very proud to have them as grantees in our Alzheimer's Disease Program Initiative State and Community Grant Program, and we hope that you will learn a lot from what they have to share today. Thanks again.
Thank you so much, Erin. So as you heard, today's presenters are Stephanie Shivers and Jane Gruner. Stephanie Shivers is an occupational therapist and the Chief Operations Officer of Community Services for LiveWell, a dementia services provider located in Plantsville, Connecticut. For the past 10 years, Stephanie has been working to bring new occupational therapy services to people living with dementia in the community and is now implementing 3 occupational therapy interventions to people living with dementia in the community through LiveWell's Administration for Community Living Alzheimer's Disease Programs Initiative project. Jane Gruner is also with us today. She is a licensed marriage and family therapist with expertise in building collaborative, solution-oriented teams and delivering integrated services and supports within the community. After retiring from the state of Nevada as the Administrator for Aging and Disability Services, Jane joined Nevada Senior Services, a nonprofit organization focused on delivering high-quality, integrated community services. At this time, I'll turn the presentation over to Stephanie and Jane, and we will answer your questions at the end of the session. Stephanie?
Hello, everyone. I'm thrilled to be able to speak with you all today, and I'm grateful certainly to ASA and the NADRC and ACL for this opportunity. I am a frequent participant of these types of webinars, and so I hope the conversation will be helpful for everyone who's listening today. And as such, I'm conscious of the fact that some people will review the slides after the webinar, and so I've tried to include quite a few details on my slide deck, so I apologize for that in advance if it feels a little dense. And if I go through the slides quickly, please know that you have access to all of the information after the webinar. Just to give you a little bit of a backdrop of LiveWell, we are a not-for-profit organization that was founded in 1990 as the Alzheimer's Resource Center, and since that time, we have been pioneers and thought leaders in dementia services, really seeking to positively transform the way people living with dementia are viewed, are engaged, and supported. LiveWell has a campus in Southington, Connecticut, which is the home to 133 people who are all living with dementia in both skilled nursing and assisted living communities. And we have direct contact with about another 600 or 700 people on an annual basis. We have quite a comprehensive suite of community services for individuals with dementia and their families, including a day program, an early stage outings group, a la carte services, support groups for people living with dementia and care partners. And we offer a wide variety of education offerings on dementia and related topics, as well as specific education programs for both people with dementia and their care partners. We have a navigation program and coaching services for people who've been recently diagnosed and for families who are trying to figure out how to move forward and build resilience now that dementia has come into their lives. And we have a group practice of dementia specialists, including a geriatrician, palliative care physician, occupational, physical, speech therapists, and licensed clinical social workers who all work collaboratively to meet the needs of families impacted by these conditions. We lead several dementia-friendly initiatives, and finally, we're the home of the LiveWell Institute, which is the research, education, thought leadership, and advocacy arm of our organization. The Institute particularly is focused on transforming communities to advance the well-being and inclusion of people as they age. So hopefully you can see how offering community-based occupational therapy interventions and services for people with dementia and their care partners fits into the overall work of our organization. Whenever I speak about occupational therapy, I always start with a level-setting question of what is occupation? You can imagine that with a word like occupation in the title of our profession, people may believe that we only focus on people's work, and probably most of us who've worked with older adults have had at least one person say to us, "Why do I need occupational therapy? I haven't worked in years. I'm retired." And while occupational therapists may indeed help clients on issues related to their work, that is only because work can be an important and meaningful activity of someone's daily life. Our occupations are the activities that fill our days. They are the things that occupy our time. So what then is occupational therapy? After a person experiences an injury, illness, or disease, an occupational therapist can work with that person to regain the skills they've lost or to develop new adaptive strategies in the areas that keep them from being able to fully engage in daily living. Occupational therapy is the therapy that focuses on achieving health, well-being, and participation in life through engagement in our daily activities or occupations. What does occupational therapy, or OT as we call it for short, focus on? It focuses on whatever occupies a person's time. And in order to do this, we need to know what matters to the person. What are their priorities, their values, their goals? What's meaningful to them? What are the abilities of the person? What are their physical abilities? What are their sensory abilities? What are their cognitive abilities? What are their social abilities? What's the context or the environment in which they're engaging in their activities? Sure, there is the physical environment, but we also interact in social environments and cultural environments. And finally, what does the particular activity or occupation require? What's the goal of the activity? What does one have to be able to do in a particular activity? What makes it meaningful? This slide gives you a quick list of what occupational therapy focuses on. You can see it includes what we call activities of daily living, things like bathing, dressing, eating, moving from one place to another, personal hygiene. It includes instrumental activities of daily living, which are higher level functions like managing a household, managing one's health, preparing meals, driving, managing medications. And OTs also focus on work, play, leisure, education, social participation, and things like rest and sleep. Services are covered by Medicare and private healthcare insurances when they're medically necessary. And when we think about people with dementia who are living at home in the community, you should be able to quickly see how a number of these areas can be impacted. And hopefully, you'll also see why occupational therapy is so important and necessary for this population. If we look at the current delivery of occupational therapy services for people living with dementia, we find that the primary arenas where services are provided are acute care hospitals, skilled nursing and rehab facilities, at home through medical home care agencies, and less so at outpatient clinics, generally for something like a shoulder or a hand injury. And as you can see, these healthcare settings are for people who've had some kind of a major health event. And for people with dementia, these types of events are things like a fall, which produces a hip fracture, or a pneumonia. And these events tend to occur in people in the moderate or late stages of the disease. This situation is quite disturbing for those of us who are in the occupational therapy field, because we know that if we connect earlier with people living with dementia and their families, we can help develop new adaptive strategies that can increase independence and safety and prevent or delay these types of adverse events. Right now, there's a gap in traditional OT services from the time a person receives a diagnosis until their dementia progresses and leads to this type of acute event and subsequent hospitalization and then a rehab stay, which often leads to premature institutionalization. So what do we need to prevent these scenarios from happening? We need proactive community-based services to identify people's retained strengths and abilities, to develop those compensatory strategies and adapt environments, and to educate caregivers to become care partners with people living with dementia. And we do all of this to increase well-being, quality of life, maximize function, increase safety, re-engage people in meaningful activities, which will in turn decrease distressing behaviors, falls, hospitalizations, and premature skilled nursing home placement. Doesn't that sound like a good idea? Oh, I don't hear you. I don't hear anybody on the call. Yes, it sounds like a good idea. And we're happy to report that the administration on community living seems to think so as well. Last year, we began delivering some evidence-based and evidence-informed occupational therapy services through our Administration on Community Living Alzheimer's Disease Program Initiative project. And our project, which is called Navigating Dementia, includes 4 occupational therapy interventions or protocols for people living with dementia and their care partners. And for those of you on the webinar who aren't familiar with the term intervention or protocol, think of it like a set of detailed instructions which are followed for each client, session, or visit. And we are using these OT interventions with specific target populations designated by the ACL, and you should be able to quickly see how they can be used for most people with dementia. The first OT intervention we're using is called Home-Based Memory Rehabilitation, or HBMR. We like our acronyms. HBMR was developed by Mary McGrath in Ireland over 10 years ago, and she's been working with a team from Alzheimer Scotland since 2013 to further develop the HBMR resources. And we have been partnering with Alzheimer Scotland on our ACL project and are now bringing this intervention to the States and delivering this OT intervention to people who are in the early stages of their dementia who live at home alone. HBMR is delivered in a person's home over the course of 8 to 10 sessions, and it focuses on building adaptive strategies, using compensatory memory aids particularly, adapting the environment, and identifying technology solutions. And here you can actually see an example of what we would call low-tech technology solutions. And these are checklists that have been created for a client to compensate for memory loss. These are used, obviously, in addition to more high-tech solutions like voice-activated systems, in-home sensors, phone apps, etc. And then in the sessions, the OT uses various training techniques with the client to learn these new daily routines and technologies, which will increase their home safety, medication management, and independent living. The other 3 occupational therapy interventions we are using are all interrelated, and this slide shows you kind of an overview of their development and how they relate to one another. And you can see on the left that the development of these interventions really began about 20 years ago by Dr. Laura Gitlin and Dr. Cathy Piersol and their teams with the creation of what was called the Environmental Skills Building Program, and that's seen on the dark blue box on the left. After about 10 years of work with that original program, it was renamed to become Skills to Care, which you see in the middle blue box, which is an occupational therapy-led program particularly for caregivers or care partners who are struggling with the behavioral expressions of their loved ones with dementia. And as Drs. Gitlin and Piersol got into that work, they realized the need for another program to focus specifically on appropriate activity engagement for people living with dementia. So in 2008, the Tailored Activity Program, or TAP, which is in the red box, came into being. Skills to Care and TAP were then combined into what is now called Care of Persons in Their Environment, or COPE. And the primary difference between Skills to Care and COPE is that the COPE intervention includes working directly with the person living with dementia. COPE includes all of the components of Skills to Care and builds on them, which I'll share in more detail in a minute. And then finally, in 2018, you can see that Skills to Care was adapted by Dr. Piersol and Dr. Adel Hirsch to become Skills to Care ID, as seen in the light blue box. And Skills to Care ID is the same intervention again, but it includes strategies that address the particular needs of caregivers supporting individuals living with intellectual disabilities and Alzheimer's or another form of dementia. On our ACL project, we're implementing COPE, Skills to Care, and Skills to Care ID, and HBMR. And the target populations for those interventions are family care partners and people with dementia, including those with intellectual disabilities, who are particularly struggling with behavioral expressions and managing the symptoms of their dementias. Each of these interventions consists of around 8 to 10 visits delivered in the client's home over the course of about 3 months. And all of these interventions focus on problem solving, developing the skills and abilities of the care partners, learning and implementing adaptive strategies, and identifying meaningful activities which are engaging for the person living with dementia. And because Skills to Care is embedded within COPE, I'm just going to share some of the details about COPE. Because COPE includes direct work with the person with dementia and is a more comprehensive intervention, it's gaining some nice traction on its implementation. Dr. Rick Vertinsky of the UConn Center of Aging here in Connecticut completed a randomized control trial on COPE in 2019 with 290 persons living with dementia and their care partners. Jill Sigliana and her team at Memory Care Home Solutions in St. Louis, Missouri are in their third year of an Administration on Community Living project where they're delivering COPE. Our team at LiveWell is now delivering COPE, and it also will be available at the University of Texas in San Antonio. And there are also OTs delivering COPE in Brazil and Australia. This slide shows an overview of the 3 phases of COPE. I'm not going to go into this, but I just want to note that it also shows, kind of on the bottom left corner there, the inclusion of an advanced practice nurse for 1 home visit and 1 telephone visit, which was part of the original research protocol. And both the group in St. Louis and we're adapting that just a little bit. The first phase of COPE begins with a comprehensive assessment of the person with dementia. What are their goals, priorities, interests, and what is their current level of cognition and function? And as you can see on this list, we assess those key areas of daily occupations that we discussed at the beginning of the talk. And then arrangements are made for that basic medical screening along with some general health education and advanced care planning. Phase 1 also includes an assessment of the environment, which will be adapted to eliminate hazards and to increase adaptive strategies. And finally, it includes an assessment of the care partner to identify specific problem areas that they find upsetting or difficult to manage. And as the goal of the intervention is to decrease care partner stress, the OT begins teaching and practicing stress reduction techniques with the care partner. To give you an idea of the problem areas that caregivers may identify, Dr. Fortinsky has generously shared his research with us, which you can see here. And of the 134 caregivers in his study, you can see the range of their responses. So starting from the greatest percentage at the bottom, we find that the most common problem was the caregiver's ability to take care of themselves. The second greatest problem was having meaningful activities for the person living with dementia. Other problems for the person with dementia included agitation, arguing aggression, rejecting, refusing help, issues surrounding using the toilet, waking in the night, sleep issues, bathing, dressing, and grooming. And I don't know about you, but I think that sounds like the realm of occupational therapy. So phase 2 is characterized by a cycle that is repeated 3 times. And the cycle starts with time spent on problem solving. What are the details of the identified problem? Why is it a problem? Why might the problem happen? Are there common factors for when and where it happens? Problem solving leads to a brainstorming of potential strategies, and then the key strategies are identified and then practiced. And strategies that work are then crafted into what's called a prescription to be used for that problem. And the cycle is repeated to identify 2 prescriptions for distressing behaviors and 1 prescription for a meaningful activity that is adapted to match the person's retained abilities. So what might some strategies or adaptations look like? Here are some great photos of strategies from Memory Care Home Solutions. Here you can see labels for items on the cupboards. In the photo on the right, you see simplified clothing selections, drawer labels and photos, a whiteboard with today's schedule. Modifying a task can include simplifying choices, using contrast for a visual cue, placing desired objects in sight versus being hidden in the drawer. And here are some examples of simplifying technology solutions: adaptive remotes, adapted phones, notes on appliances, timers, and closures for thermostats. And here's a sample form for prescriptions. So these actually become written documents for the caregiver. And you can see the problem identified by the care partner and the goal, and it includes reminders as to why the problem may occur, what factors of the person with dementia or the caregiver or the environment might be contributing to the problem. Clear reminders of the person's abilities are included along with specific strategies that have been identified and practiced. And strategies include what to do, what to avoid in particular areas of communication, home modifications, simplifying the setup of the daily tasks, enhancing activity participation, and strategies specifically for the caregiver to better cope. The goal of phase 3 is for the care partner to generalize their learning across situations. And the OT and the caregiver review their learning from the cycle of problem solving, brainstorming, practicing strategies, identifying prescriptions for target areas, and then they explore how their learning applies to new situations. They also review the common steps for modifying and simplifying new activities. And after the 3 phases are completed and the intervention is finished, the caregiver should experience a reduction in stress, and the problem areas originally identified should now be less upsetting and less difficult to manage. Skills to Care, COPE, and TAP are highly structured interventions which require an advanced level of training. And if you're interested in learning more about the interventions that are receiving training, here is where and how you can inquire. And if our goal is to connect people with dementia and their caregivers to the OTs that can help them develop adaptive strategies to achieve health, well-being, and maximize engagement, safety, independence, and daily activities, I wanted to certainly give you some practical tips on how to find quality OT services. So you can reach out to the contact I just shared at Thomas Jefferson University to find a certified OT in your area. Currently, there are about 120 OTs certified in Skills to Care in Pennsylvania, New Jersey, Connecticut, Florida, Delaware, Washington, Utah, and Louisiana. And I've shared where COPE is being offered. And when selecting an OT provider, you or the family want to ask who has specialty training in dementia and what training do they have. Ask what dementia-specific, evidence-based, and informed interventions the OTs are using. You want to look for OTs that are using the cognitive disabilities model. That's characterized, you may hear something called the Allen cognitive levels. And you may be wondering, how does someone get started with an occupational therapist in the first place? So a person's primary care physician can make a referral for OT, for occupational therapy evaluations, and for treatment. And if the person with dementia has progressed to the point where they're homebound due to functional and physical decline, ask their primary care physician to make a referral for medical home care services. Medical home care services do not require hospitalization. It's something that a physician can order if a person is homebound. And finally, if you're an occupational therapist listening to this webinar, or if you know of any OTs who are interested in learning more about working with people with dementia and their care partners, we invite you all to join our occupational therapy community of practice. This group will meet quarterly to share best practices for dementia and provide ongoing professional development and continuing education in ongoing evidence-based and evidence-informed interventions. And you can join the meeting via video conferencing. And for more information, you can contact Kate Keefe, whose information is there, and the next meeting of that group will be on February 20th at 6 p.m. Thank you so much for your attention, and certainly feel free to ask questions at the end or reach out to me directly with any questions. Thank you.
Thanks so much. We'll move right on to Jane Gruner.
Well, good afternoon. Thank you for the invitation to speak today on one of my favorite topics, the integration of social workers into community-based supports for people living with dementia. Today's objectives will include learning about our community approaches to the integrating of social work activities into dementia programs. You'll learn about the identification of the National Social Work Practice Standards for family caregivers of older adults, and learn knowledge on the Alzheimer's Association Dementia Care Practice Recommendations. But first I wanted to tell you a little bit about Nevada Senior Services. Nevada Senior Services was established in 2001 as a nonprofit organization providing compassionate care and services to adults and their caregivers. The focus was really to develop a quality program that supported families as they faced the challenges of aging. The goal was to support people to remain in the community with dignity by providing a comprehensive range of services. Located in Las Vegas, Nevada, Nevada Senior Services fills a critical service gap in key community services within Southern Nevada. This area includes urban, rural, and designated frontier areas. Now, just to give you a little bit better picture of the area we're talking about, beyond the glitz of the Las Vegas Strip, Nevada has a land mass of 110,000 square miles and a total population of just over 3 million people. 2.7 million of those people live in southern Nevada. So part of our challenge in this area is to be able to reach out to people who live hundreds of miles from the service locations. As Nevada Senior Services began to focus on meeting the needs of a growing community and filling the gaps within the social service areas, one unmet need really stood out above all the rest. And that need was for quality programs for individuals living with dementia and their caregivers. Nevada Senior Services began to focus on dementia-capable initiatives in 2006. We quickly recognized that the Adult Day Health Center was critical to sustaining a family's long-term goals of keeping their loved one at home. The Adult Day Health is able to provide quality services for the individual, such as maintaining their skills and providing meaningful activities throughout the day, and at the same time was able to provide families with the information on services, educate them on best practices, and to support family partners with a social worker who could help them develop a person-centered care plan for their loved one. This program allows care partners to continue to work to support their families if that's needed. Some of the other initiatives that we have put into practice were a comprehensive geriatric assessment center. The program enabled a person to obtain a complete medical evaluation in one day, and the members of that team included geriatricians, social workers, occupational therapists, and nurses. The assessment encompasses all of the client's health needs, their disabilities, cognitive abilities, medication reviews, self-care abilities, their ADLs, their IDLs, their health-related lifestyle habits, psychological conditions, environmental risks, and also the client support system. So at the end of the assessment, the person receives recommendations, a handwritten or a written plan of care, and referrals to needed programs and services within the community. This program made it easier for the client and the family by providing the service in one place and on one day. They received the assistance needed to obtain the appropriate services and a social worker to help them make their referrals. In addition, the program helped train the next generation of physicians, so it also met a community need. They trained the next physicians, nurses, social workers, and occupational therapists because it is a collaboration with the local medical school. So as our experience and knowledge advanced in working with individuals living with dementia and their caregivers, the role of the social worker within our agency really expanded. So over the last 15 years, we have integrated social work components in a variety of programs. Using a geriatric interdisciplinary team approach, our social workers are uniquely positioned to promote health education, create person-centered care plans, and advocate for needed health and social services. Our social workers recognize the primary importance of human relationships. They understand that relationships between people are important vehicles to change. Improving relationships restore and promote functionality. Nevada Senior Services offers an array of social work directed programs to support our efforts to serve individuals living with dementia and their care partners. All of our initiatives are designed and based on the needs of our consumers, their families, and our community. Social workers play a crucial role in this population. case management provided by social workers has been built into most of our programs, as it is essential for supporting the care partners who are typically exhausted by the time they get to us from the caregiving duties. So as an example, I'm going to share two of our programs of which we use social workers. So one is our transitional care services, specifically for people living with dementia. And that is our hospital to home initiative, which is funded through the Administration of Community Living. The transitional care service consists of a 30-day social work-led program to assist individuals transitioning from hospital to home. The social worker provides intensive case management to assess the individual and the family needs and identify the supports and services needed for a successful transition home. The team works to find solutions for any of the issues that are preventing the individual from living safely in the community. So the services and supports are wrapped around the individual and the family to improve the health status as well as their emotional well-being. They continue services are also put into place if the family and the individual need additional services beyond the 30-day. The program works with the hospital staff and community providers to ensure that all the aspects of the individual's care needs are addressed. The case manager, which is the licensed social worker, develops the care plan and helps to implement that care plan once the person returns home. In addition, the social worker helps guide our respite coaches, which are also part of this program, to deliver education and specific training for dealing with the special needs of the individual living with dementia. In addition, the respite coach provides intensive respite for the caregiver to give them a break from the daily duties of caregiving. So our next program that I wanted to talk about was our evidence-based or evidence-informed caregiver programs that are specific to for partners of persons living with dementia. And the key program that we are providing is the RCI REACH program, which is licensed through the Rosalind Carter Institute on Caregiving. And this program is an in-home caregiving support program that is tailored to the needs of each individual family. The social worker provides one-on-one support and education either in the family's home or on the telephone. The evidence-based education includes a focus on safety for the person with dementia, support for the caregivers, and skill building to help the caregivers manage difficult behaviors. Now, on our journey towards supporting individuals living with dementia and their care partners, we have found great value in the use of standardized assessments. All individuals receiving services complete the assessments listed on this slide. So they complete a health and physical well-being questionnaire, a health care utilization, how many times they go to the ER or the hospital, a patient health questionnaire. They're given a Montreal cognitive assessment and the CATS, which investigates their ADLs and their IDLs. Now, in order to understand the individual, our social workers assess the person's current level of health, cognition, and their abilities. This supports the social workers in identifying the needed areas of support and helps them set the priorities to help that individual live their best life in the community. They are assessed at the intake and then throughout their treatment or their participation in our programs. And with that, whenever they're assessed, there's their adjustments are made to the care plan if they're needed. Now, in addition to the standardized assessments that are given to the individual receiving services. We also do assessments for the care partners. And very similar with the addition of, we also add the ZERIT screen measure of caregiving burden and the desire to institutionalize. Now, in order to understand the needs of the individual with dementia, we really need to understand the care partner and the dyad between the two. So the assessment identifies the important aspects for both the care or consumer and the care partner. Additionally, we use this information to help assess what's going on in our programs, and we use the data to drive our decision making for where the organization will go and what programs they'll add on to this array. During the past decade, consumer advocacy groups and professional organizations and governmental agencies have really taken a really great interest in the role of family caregivers in supporting older adults. As a result, healthcare professionals are focusing on their ability to train members of their respective disciplines and to contribute to increasing the knowledge of gerontology and in supporting family caregivers. This is really very true for social workers. The National Association of Social Workers is the entity that governs the social work practices offered in community-based approaches. And in 2010, the National Association of Social Workers produced the Standards for Social Work Practice with Family Caregivers of Older Adults. The 12 standards that were designed are designed to enhance the social workers' awareness of the skills, knowledge, values, methods, and sensitivities needed to work effectively with family caregivers. For the purpose of this webinar, I have selected 5 of those standards to review, as I think they're relevant for today's discussion on integrating social work practices with approaches to support people with dementia and their caregivers. But I strongly urge any programs that are going to be using social work components to really understand all 12 of the standards and to weave those standards into their social work activities. So we have the 5 standards that I've selected are ethics and values, assessments, service planning, delivery and monitoring, collaboration, and professional development and competencies. So what we're going to do is look at the major concept and then look at ways that you could implement that concept into your programs. So for the ethics and values, social workers that are practicing in this profession with this population typically are confronted with very difficult situations often. The National Association on Social Work provides a code of ethics as a guide for decision making, and they use those, and all of the licensed social workers have to follow this code of ethics. One of the ways that Nevada Services has woven the standard into at the program level is to implement a weekly peer review of clinical cases for the hospital to home program. This is a program that supports individuals living with dementia that are typically quite complex. They have a lot going on, and for most of the referrals that we have gotten for this program, the individuals are well into the disease, and so they have they often have behavioral symptomology that is adding to their distress and to their caregivers' distress. The review of complex issues within our care team and our clinical teams support the clinical staff in their decision making and provide expertise from more seasoned team members that may have a broader scope of practice. The ethical decision making and the value clarification during the case reviews is especially helpful because often we're dealing with individuals that may not be able to state their view anymore just due to their cognitive issues. The second standard that I wanted to talk about was assessment. The biopsychosocial assessments are one of the foundations of social work practice and are conducted in collaboration with the family system. But assessment, in this case, is an ongoing activity. It's not a one-time event. Our social workers use their foundation of assessment to do their planning, and their comprehensive assessment is developed from all of the interaction that they have with the individual and the assessments that they have used. The ongoing assessments assist the social worker in making revisions to the care plans as the person's needs change. The use of the standardized assessment instruments, such as the care burden scale can aid the social worker in identifying and responding to a caregiver's concerns and set priorities for how essential it is to get certain elements of the care plan started. Social workers in our program provide assessments for both the client and the caregiver. This really helps identify the urgency and the needs that allow the social worker to take immediate action. In assessing both the members of the Dyad, we have found that both members are experiencing, sometimes both are experiencing cognitive difficulties. So the information really helps the social worker and the family structure what types of services that they need. The third standard, the standard of service planning, delivery, and monitoring, is really the key issue for most service coordinators or social workers going into the home. It's really the workhorse, I would say, for a social worker. The activity is one of the key successes for a social worker and for helping a person living with dementia. In collaboration with the individual and their care partner, the social worker can develop the care plan to address all the issues and all the areas that the person may have and able to live their best life. So it is the person's personal roadmap, basically, for moving forward and update, and they're often updated as the person's life journey changes. The fourth standard is collaboration, and that includes the social work, interdisciplinary work that's done between not only our internal staff, but our system partners. One example is, as I mentioned earlier, Nevada has rural and frontier areas. So when Nevada Senior Services social workers travel to these areas, they often invite other organizations to join them. So our social worker may provide some of the outreach, such as presenting an evidence-based training, such as dealing with dementia for the caregivers and professionals, in collaboration with the other entities who may be offering information on, say, food insecurity or fraud prevention, or maybe housing. But it allows for the teams to work together to present the most important information and to allow our rural and frontier areas to be able to access that type of engagement with professionals. The last one I wanted to talk about was our professional development and competence. Social workers have a personal responsibility for their professional development and competence. The ongoing professional development increases the social worker's effectiveness and expertise in supporting the family caregivers. So Nevada Senior Services social workers are encouraged to both attend outside training as well as offer outside training or offer training to others. In our hospital to home program, it has been amazing that the social workers regularly provide training to the medical professionals, and now the medical professionals are inviting them to their training, sometimes doing rounds with them. which really has enlightened our social workers to the aspects of what's going on in the hospitals. So embedding the social work practice standards within your program will really help assure ethical services are being provided. Programs supporting individuals living with dementia and their families are encouraged to adopt the Alzheimer's Association's 2018 Dementia Care Practice Recommendations. This is a group of 56 recommendations that were developed to better define quality care across all settings. They are intended for professional care providers, such as social workers, who work with the individuals living with dementia and their families in residential and community-based settings. It is a person-focused core of recommendations, and basically everything for quality concerns being person-centered. So the main philosophy behind providing quality dementia care is making it person-centered, meaning that the individual is at the core of all the recommendations. So with the fundamentals of person-centered care as the foundation, the dementia care practice recommendations illustrate the 9 elements essential for providing that quality dementia care. The graphic in the slide illustrates the elements used to develop the quality program, and that includes person-centered care, detection and diagnosis, assessment and care planning, medical management, information, education and support, ongoing care for behavioral and psychological symptoms of dementia and support for activities of daily living, staffing recommendations, supportive therapeutic environment and safety, and transitions and coordination of services. For additional information on this, you can find it on the Alzheimer's website. So when we put it all together, we have 2 programs that are social work led and really developed by the social workers within the programs. The first one is our Memory Care Cafe, and that is it's a social work led small group. The goal for the individuals is to maintain their skills for as long as possible. So the social workers develop themes for each weekly session and then build upon those themes using activities that encompass all of the individual senses. Every group will include memory strategies, food, music, physical activity, sensory activities, and conversations with the group. And the social worker is especially skilled with helping the individuals transition to other programs as their cognition changes. In addition, the social workers offer a support for the care partners of the individuals participating in the Memory Cafe. The impact of this has been, it's an opportunity for our social workers to assess the individual on a regular basis. The weekly group gives the social worker time to do that assessment, to advocate for the individual as the person needs change, and the social worker is able to be proactive in supporting the person to live their best life. So the relationship the social worker develops with the individual and their care partner over time make them probably the most knowledgeable and highly sought after by other team members. They are often the first professional to notice the subtle cognitive changes within an individual. So our next one is our current ACL grant, which is hospital to home. And this supports person transitioning from hospitals to their homes. Again, I talked about it earlier, and it's basically we took the Bridges model from Rush Hospital, and we instituted their core piece and then put add-ons to it to address dementia issues. So the Care Transitions program provides that intensive case management to people living with dementia and their care partners. As mentioned earlier, the social work-led group is provided for 30 days of post-hospitalization. The social worker works with the individual and the family to identify whatever needs and supports are needed, and then assists the family in implementing the needs. They assist with medical appointments and other obtaining medications, and problem solve any of the issues that the family is having that they're unable to solve on their own. So the social worker helps wrap all those services around the family during the 30 days, and then the social worker will assist the individual and the caregiver to set up ongoing services if they need additional services past the 30 days. They are offered intensive respite coaching and intensive respite services. One of the probably the best results that we have gotten is that with the social workers working with their interventions to implement the care plan, what we have found is a significant reduction in readmissions to the hospital within 30 days. And Nevada has especially in Las Vegas, has one of the highest readmission rates for people in the country. And this program has been able to reduce admissions to an extremely low level. The program has increased the health status for both the recipient and the care provider, as well as reducing dementia symptoms and reducing the care burden. So in finishing, I'd like to tell you a success story. This is a story of one of the families that has used the program. The hospital-to-home program received a referral from a Valley Hospital regarding Joy, a 75-year-old female who has been hospitalized for a urinary tract infection and was living with moderate to severe dementia. Her husband of over 50 years, Bob, was her caregiver. The licensed clinical social worker and the respite coach met with Joy and Bob in her hospital room. The social worker explained the program to the couple, agreed to participate. So during the assessment, Bob voiced his concern regarding his inability to help Joy and to get her to her doctor's appointments due to her extreme agitation and her inability to follow the suggestions that he makes to her. He also requested help supporting Joy in her toileting activities. The social worker was able to work with Bob and Joy to address the family's concerns. So over the course of 30 days, the social worker completed a comprehensive assessment in collaboration with Bob and Joy and created a care plan that both agreed would be helpful. The social worker arranged for occupational therapists to assess Joy and provided home modifications that were completed. A ramp was installed in the garage and a toilet riser was installed in the bathroom. The changes allowed Joy more freedom in her own house, as well as helped her to be able to toilet on her own. The social worker was then able to arrange neurological care for Joy and attend the appointments with the family. Bob learned the strategy for supporting Joy that helped her reduce her agitation, and she was able to go out with Bob more often. She was also able to attend her doctor's appointments and lab tests without any incidents. The respite coach provided education and coaching to Bob on ways to address the behavioral concerns. In addition, the respite was provided for Joy so that Bob could get a break from caregiving. He was able to engage socially with his friends again and also attend a regular golf game. So the social worker initiated continued services so that Bob would be able to continue his socialization and be able to have a regular respite provider. In addition,
Jane, I'm gonna cut in because we want to get to a few questions before the end. We don't want to run out of time. There's a great success story, and great, good, and great presentations. Thank you so much for all the fantastic information. I just wanted to get to a few questions. Stephanie, a few came in for you. One was asking about the interventions you mentioned, if they require a care partner's involvement or if they can be delivered directly to the person living with dementia.
Right, so home-based memory rehabilitation can be, that's directly with the person living with dementia alone. Both skills to care and COPE, those interventions are for the Dyad. Those require a caregiver.
Great, thank you. And that was a quick one, so I just want to ask you one more that came in. Do you have any examples of the empirically derived care strategies that are prescribed to the caregivers?
Well, some of the ones that I gave you the photographs of, those were all kind of those are typical examples of what happens. I don't know whether you're asking more specifically or the person's asking more specifically about for the caregiver addressing their own needs or more generally. But what I can tell you is that all of the kind of the action plans or the prescriptions, they all contain strategies around communication, around adapting the environment, about simplifying the activities, increasing engagement and activity. And those kind of 4 themes have been developed over years and through years of research on these interventions. And so I can certainly provide more specifics. Whoever's asked the question, if they just want to reach out to me, I can certainly share the research behind all of the interventions.
Great, thank you so much. I just want to get one more question answered. Jane, can you just briefly mention what other disciplines are working with the social workers in the hospital to home program to assess the folks that they're working with?
They are working with hospital discharge planners, physicians, nurses, and occupational therapists.
Great, thank you so much. I do want to thank everyone for attending the webinar today. What a lively session we had and great presentations. I do need to turn it over to Steve Moore from the American Society on Aging for some final remarks so everyone can know what their next steps are. Thank you so much.
Thanks for joining us today, everyone. It's time for us to wrap up. We've reached the end of our hour here.